Here's what's coming up on your horizon. Well, we spend more on healthcare than any other nation, but Americans aren't necessarily any healthier. While the U.S. may lead in medical research and sophisticated new treatments, Americans continue to get steadily heavier as the years pass, and nearly 1 in 5 of us still smokes. Today, our focus is on health and its impact on our economy. We travel to rural Oklahoma to ask, is there a doctor in the house?
Not only do we have less physicians than most states, but we have an aging physician population in rural Oklahoma.
We'll look at why even getting to the hospital can be a challenge in some parts of the state.
How many lives is it willing to sacrifice before they're willing to do something about this deplorable problem?
Stay with us for Oklahoma Horizon.
Oklahoma Horizon is made possible by the Oklahoma Department of Career and Technology Education.
Oklahoma's investment in career tech provides more than nationally recognized technology education and training. It produces solid financial returns for the state's economic future. Oklahoma Career Tech, elevating our economy.
And the Oklahoma Department of Agriculture, Food, and Forestry, helping good people grow good things. And now, from the Career Tech Studios in Stillwater, here's your host, Rob McClendon.
Hello, everyone. Thanks for joining us here on Horizon. Well, our nation's healthcare system has enough problems to give anyone a headache, and that probably goes double for our nation's lawmakers. Sober reality is that healthcare spending is on the rise, pinching already strapped household budgets and sapping our country's fiscal health as well, and that's fiscal with an F. Now, when it comes to medical care, the affordability outlook is tough for both the government and consumers. Today, we face the facts on the health of our healthcare sector. Here's Frank Sesno.
As a nation, our healthcare spending is 10 times what it was back in 1980. If you were around then, chances are you don't feel 10 times healthier, but you may be feeling the squeeze.
We like to believe our medical care is the finest in the world. Certainly the most expensive, $2.6 trillion in 2010. Rising costs are blamed on many factors: more chronic disease, expensive technology and treatments, more specialists, more prescription drugs. But money doesn't always buy results. One example, maternal mortality during childbirth has actually doubled in the past 25 years. How did that happen? The high price of our health care bites into consumer wallets and corporate budgets alike. It's also a bigger burden on taxpayers, as Medicare picks up the tab for just about everybody over 65. So the question now is, how long can this go on? Healthcare reform will make insurance available to 50 million people the Census Bureau says have no coverage at all right now. So as we try to cut costs without cutting off necessary care, what are the trade-offs? Technology? Bio breakthroughs? The ability to choose the doctors we like? And what's our role in all of this? Healthier habits don't take an act of Congress, but 19% of us still smoke. A third of Americans are obese, another third overweight. Hello, diabetes, heart attack, stroke, the real killer apps that can propel healthcare costs into the stratosphere.
Controlling costs, maintaining access, getting more high-tech care, curing disease. A lot to do, hard to pay for, but we have to face the facts.
And while we're spending more on healthcare, we are making less. Healthcare spending per capita in the U.S. increased 36% between 2000 and 2010, from just over $6,000 to nearly $8,500 for every person in the country. Now, during that same period, inflation-adjusted pay went down approximately 6.4%, from $28,000 in 2000 to over $26,000 in 2010, which makes the pinch from rising healthcare costs hurt just a bit more. When we return, we focus on rural healthcare.
You're watching Oklahoma Horizon, featuring some of the good things that are happening in the great state of Oklahoma.
While healthcare is jarringly expensive and is likely to get even more so, in some parts of the state, availability is even an issue. Joining me now is our Keela Kellen.
Well, Rob, a question that has increasingly been asked in parts of rural Oklahoma: is there a doctor in the house? And that's the reason behind a new program to bring more doctors to small towns. Medical students wanting to practice in rural Oklahoma are in the minority. Mercedes Bernard is in that minority and wants to provide health care to smaller communities.
I'm from Granite, Oklahoma. The population is a little over 1,500. I graduated with 22 in my high school, and I'm in love with rural Oklahoma. I never thought in a million years that I'd want to go back, and then you get to Tulsa, and it's big city living, and it's not for me. It turns out I miss the country girl at heart.
Currently, Oklahoma ranks 43rd in the nation for meeting residents' medical needs, in part because of the shortage of rural physicians.
Compared to other parts of the United States, we have less primary care physicians than most states.
Casey Schrum is the dean of the College of Osteopathic Medicine and says the school is focusing on producing more rural physicians.
Our mission is for rural and underserved areas of the state, so that's a big concern for us. And when you look at Oklahoma, it's even more so that in the rural areas of the state, our physicians are older also. So not only do we have less physicians than most states, but we have an aging physician population in rural Oklahoma.
Approximately 20% of Oklahomans live in rural areas, but only 9% of state doctors practice there.
We know we're not likely to train someone who's grown up in an urban community and expect him to go out and be comfortable practicing in rural Oklahoma. So that's really been our approach. It's somewhat different than the approach that we've taken to recruiting medical students in the past, but I think it's a critical piece for us to be successful and for us to help meet the needs of Oklahoma and our mission.
Targeting students like Mercedes and Kevin with a rural background.
I feel like when you're in a small community, everybody, it's like it becomes an extended family to you. Like everybody in your community is extended family. And so I think that that's kind of why I'm drawn to like returning back home. They had such an influential part in, me getting into medical school and just, providing a lot of support and a lot of encouragement. And so it's like, I kind of feel like I want to return back to my family and, give back a little bit.
Check the periphery.
Growing up in a small town, Kevin Johnson wants to return home where he can make a difference.
I graduated with 13 people in my senior class, and one of the reasons I like rural medicine is, A, there's a need. There are no physicians in Johnston County, and seeing my family, growing up with limited access to health insurance and health coverage, there's such a need that I feel like I'm drawn to that area. It's comfortable, it's familiar. I feel like I could really, make an impact with my family and friends.
But he knows it won't be easy working in an underserved area.
It's challenging because you are the go-to person. You could be the only doctor within miles. So you have to keep track of your education, keep up your skills in all areas, and you never know what's going to come through the door. So to me, that's very exciting and challenging.
Nationwide, 66% of people live in an area that the government recognizes as medically underserved.
So are programs like this, are they making any dent in the problem?
Well, Rob, they have been making a dent. Actually, last year, Oklahoma went from 48th in the nation to 43rd, which is certainly a step in the right direction.
All right, some good news. Thank you so much, Keelan.
You're welcome.
Still to come on Oklahoma Horizon, helping rural students find a pathway into medicine. But first, goodbye, city lights.
Well, one of the strategies to attract more doctors to small towns is to expose them to the rural lifestyle. OETA's Kathy Tatum has been following a class of new physicians as they leave the city for life in the country.
Joshua Priddle grew up in Martha, Oklahoma, a tiny town just outside Altus in Jackson County.
Hi, how are you?
These days you'll find him at Hastings Hospital in Tahlequah. It's where he's doing his first internal medicine rotation as a third-year medical student. Priddle and a dozen other medical students are part of Oklahoma State University Medical School's first Rural Physician Track program.
Well, can I go ahead and take a listen to you?
Okay. During traditional physician training at OSU Medical Center in Tulsa, third-year students often do more observing than personally interacting with patients.
Any fever chills?
No.
Nausea, vomiting?
No.
Frequently, groups of 15 or more students and doctors doing their residency training assess patient ailments and injuries.
I had an abscess in it.
But in this small hospital, there's no crowd.
So a lot of the things that I learned in first and second year, I'm relearning, but they tend to stick a lot more. And so I think that was the biggest one. That's the biggest advantage of being able to have early patient encounters.
Dr. Douglas Nolan heads up the family practice residency program at Tahlequah City Hospital. He says medical students frequently opt out of family medicine to pursue a specialty once they begin their third or fourth year training rotations.
It's projected that there is going to be a large physician shortage, especially in primary care. Over the years, what's happened is after the students go through medical school, they get interested more and more. We're becoming more specialized. So what happens is they go into more and more specialties. It's actually more money, but those specialties are generally drawn to the larger areas. Therefore, there's more and more of a shortage for the rural areas for primary care.
Dr. Nolan hopes the amount of interaction students get with patients in small hospitals will keep them on the rural track and focused on becoming family physicians. He believes spending time in small-town hospitals will eliminate concern among medical students that training is better in urban rather than rural settings.
What some people don't understand is the training is actually comparable, if not exceeding, what they get in the more urban areas. And the reason why is a lot of the pathology is kept here, and so it makes for great training. We have the specialists that they do in the larger areas, but with more one-on-one teaching and more interaction with the patient, I think you're going to see a great benefit to the rural communities as we put more and more physicians there.
After the first week was over, one of the respiratory therapists came up and said, hey, you want to do an extubation, which basically removing a tube out of somebody, and they let me do that, and I didn't really expect to get to do that.
They're not competing for the patients. Therefore, what happens is they get better one-on-one with the patients. They get to see what the standard of care is and actually be very integrated into the care of the patients. It allows more one-on-one teaching with the attending physicians. Actually makes for a much better experience. They also get to see things how it's done, where you need to take care of the patient more in the primary care role instead of referring everything to the specialist. So they actually get to be more of what they train to be, and that's to be a very competent primary care physician.
And a primary care physician that wants to spend his or her career serving patients in small-town Oklahoma.
Now, everyone who works on the rural doctor shortage will tell you it's easier to keep potential rural doctors at home rather than attract urban doctors out of the city, which is why the medical field is now a new emphasis in ag education classes. Once again, here's Kathy Tatum.
We could talk about ethics all day long.
Bailey Diffie is a senior at Coweta High. Throughout her high school career, she's participated in FFA, Future Farmers of America classes.
This is Ying, my sheep.
For her class project, she's raising a sheep to enter in livestock shows.
I work with him every evening and walk him and teach him to brace, and that's going to pay off in the show rings.
Diffie is among the first FFA students in Oklahoma recruited while still in high school to consider a career as a rural physician.
I've always wanted to be in the medical field, but I never knew what I wanted to do. And then talking to Dr. Schrum helped me out a lot.
Dr. Casey Schrum is the Dean of the College of Osteopathic Medicine and Provost at the Center for Health Sciences at OSU Tulsa.
We have a pretty big issue with the shortage of primary care physicians in rural and underserved Oklahoma.
To reduce the shortage, OSU is taking an unusual step. It's teaming with FFA to encourage rural high school students to become doctors dedicated to practicing medicine in Oklahoma's smallest communities.
We have to look at doing things differently than what we've done in the past. Medical schools have typically, reached out to college students and encouraged college students.
Reaching out to high school students, especially those participating in FFA, targets a group of potential physicians already familiar with country life. Schrum says 4 things have a really big influence on where doctors practice medicine.
Where they grew up, where they went to college, if their medical school has an emphasis on primary care and rural health are underserved within their curriculum, and then where they do the residency program.
Hello, Miss Rossi, how are you doing?
So, in addition to encouraging FFA students to become doctors, OSU created a special rural health tract for its physicians already in training.
How are you feeling?
I'm feeling a lot better today.
This past year, the Oklahoma legislature passed a bill that will help us develop residency programs in rural Oklahoma.
Durant, Enid, and Tahlequah are established, and we're trying to get Lawton started up for western Oklahoma.
For the first 2 years of medical school, students in the rural physician program live and train in Tulsa at the OSU Health Sciences Center.
But now I'm thinking that it's more likely related to the incision.
For the next 5 years, they train in rural hospitals. Dr. Charity Holder finished medical school training in Durant. Now she's doing her residency in family medicine at Tahlequah City Hospital. She says the program gives participants more hands-on experience than a typical big city training hospital.
I talked to some of my colleagues up at OSU, and they said that on their OB month, they only got to deliver 2 babies, and they technically didn't get to deliver them, they just assisted. Well, my classmates and I that went down to Durant and Amanda Reed and Tahlequah, our comparison charts, we were delivering 30 babies a month. You know, we were catching them. We actually got to do all the procedures. We were first assist, whereas third-year residents didn't get to be an assist. We got to first assist on all these really awesome procedures. We were in surgeries all the time.
When Holder finishes her residency, she plans to practice in her hometown of Colgate. Dr. Shrum says having a physician in a small town doesn't just keep the community physically healthy.
In order to have industry in rural areas of the state, in order for the economies in rural area to flourish, they really need a physician there.
Page 9, where we ended up Friday.
So, Shrum believes when FFA classes sow the seeds of interest in becoming country doctors, it's as much about securing Oklahoma's future rural health care as it is about cultivating our state's rural economic health.
Oklahoma Horizon is now portable. Just subscribe to our weekly podcast. Visit iTunes.com, where you can download our show for your listening or viewing convenience.
Well, the first decade of this century was actually a period of pretty low inflation, but not everyone got the memo. The cost of the average American hospital stay nearly doubled from the year 2000 to 2010, while the average stay length actually declined. If you will, let's face some facts. Charges for hospitalization soared from an average of just over $17,000 in 2000 to right at $33,000 in 2010, almost doubling in just one decade. Now, here in the U.S., we spend almost 3 times as much on a hospital stay as other industrialized countries, even though their average stay tends to be a bit longer. In Japan, hospital stays average 18 days, while here in this country, the median stay is right at 5 days. Yet we still pay almost triple what the rest of the developed world does. Now, the average hospital stay in the U.S. comes in right at $18,000 per patient, compared to just over $6,000 per patient for patients abroad. Now, if you'd like to see more facts just like this, we have daily updates on our website, courtesy of our friends at Face the Facts USA. Plus, we also have a link to an interesting story on the history of health reform in this country through the artwork of some of our nation's best political cartoonists. To see that feature, plus much, much more, just head to our value-added section at okhorizon.com. In addition to the shortage of rural physicians in some parts of the state, emergency medical services like ambulances and EMTs are also in short supply. Joining me now is our Lisa Hines.
That's right, Rob. Oklahoma's emergency medical services are in crisis mode. Since 2001, over 50 EMS services have closed their doors, leaving many Oklahoma residents without emergency care. In 2011, House Bill 1888 was signed into law, creating the Ambulance Service District Act. Its intent? To end the decline of emergency medical services here in Oklahoma. And while the law was put into place, funding for it was not, which is why lawmakers held an interim study to figure out how to keep Oklahoma's EMS systems viable.
When a medical emergency happens, you naturally expect help to be a phone call away. But according to Rodney Johnson, director of the Medic Institute, our state ambulance services are at unsafe levels.
The fact of the matter is this business model of the way we have been delivering emergency medical care no longer works and is on the verge of collapse. I call it the #1 public health threat that no one's ever heard about.
And in a time when the legislature is looking at cutting taxes, Rodney fears that could have deadly consequences.
When I started this process with Medic Institute 5 years ago, the floor leader of the House of Representatives told me that sometimes in the state legislature, things have to totally collapse before we do anything about it. Well, in the EMS business, that costs lives. So the state legislature needs to decide how many lives is it willing to sacrifice before they're willing to do something about this deplorable problem.
It's a problem that legislator Seneca Scott feels needs to be addressed.
Well, it's important on a lot of different levels. I think that in part with just the tightening of resources we've seen statewide, nationwide, internationally, there's an ongoing effort to make the most bang for our buck. For now, also, in addition to the expenses, is also the weighty matter of public safety and getting people, the proper medical care needed.
Now, according to Rebecca Smith with the Oklahoma Ambulance Association, a special district may be one way to address the issue.
522 districts are ambulance service districts. They can either be by county or by city, or they can be by school districts, and they're funded in part through ad valorem taxes or property taxes.
But funding is still an issue.
We need them to realize that there's no one fix. Nothing is going to solve the problems that we have in EMS, but if we all work together, we can all have a piece of the different things that may help, and removing the cap or eliminating the cap of 3 mills, which has not changed since 1977, would be a small part of how we can help EMS services across Oklahoma shore up and maintain their ability to respond to the people who need them. There are many solutions, which we're so grateful that they're having the interim study, because this is a start to finding those solutions. It takes all of us working together.
The fact of the matter is, it takes a certain amount of money to run an ambulance service. It takes a certain amount of money to be able to have a well-educated workforce that is able to respond in today's medical environment. So while it is a local issue, there's no two ways about it. This is a problem that the state has to put some money into. I believe my best estimate is $40 million is what it would cost in today's money to be able to fix a lot of the problems that are associated with emergency medical care now. Where's that $40 million going to come from?
A good question, and one these EMS supporters believe legislators need to focus on.
Now, one solution proposed at the interim study was for an EMS tax to be included on utility bills. The only problem is that while rural electric companies didn't seem to have a problem with that, the Public Service Company of Oklahoma, or PSO, says they don't collect taxes in lieu of their fees that customers haven't voted on.
Now, I can see where that would be greeted with enthusiasm by some folks, because it spreads the taxing base out to people outside of just property owners and ad valorem taxes to anyone that pays utility bills. Now, before you go, answer me this. Is there any EMS system that is actually doing all right?
There are a few, and one in particular that really impressed me is in Craig and Delaware counties. It's called the Regional Emergency Medical Ambulance Service, and it was formed through the work of a public citizens community from Craig County and the towns of Veneta and Cleora. And with 3 funding sources, they're able to keep their ambulance service open 24/7 to the entire area. And they say being able to combine it, they can give this service at a lower cost than if they had the services separate.
Well, it certainly sounds like a good example of communities working together for everyone's economic benefit. Thank you so much, Elisa.
You're welcome, Rob.
Now, if you'd like to see how one young EMT is using both his faith and the latest technology to serve his small town, just head to our website and look for the Paramedic Preacher under this week's Value Added. Next time on Oklahoma Horizon, we look at the Browning of America.
We are still a very young population. A third of the U.S. Hispanic community population is still under the age of 18 and has yet to enter the workforce. We're basically witnessing is a second version of a baby boom, if you will.
Oklahoma's changing demographics on Oklahoma's Show for the Heartland, Oklahoma Horizon. Well, we are out of time. I'm Rob McClendon. Thanks for watching. See you back here next week.
Horizon is made possible by the Oklahoma Department of Career and Technology Education and the Oklahoma Department of Agriculture, Food, and Forestry. Thank you for watching Oklahoma Horizon.